All right, welcome everyone. Thanks again. Some familiar faces here in the audience. My name is Naveen Kella. I'm a urologist. Actually now I've been here in town for actually 10 years. I fellowship trained in oncology, did a lot of, kind of started the robotics program here in San Antonio for prostate 10 years ago. And actually, I just want to introduce my newest partner, Michael Nasmi. He's a urologist. Actually, he did his fellowship as well. He's fellowship trained. He was at City of Hope in California. It's a very prestigious program, and he completed a robotics fellowship as well. And when you do a robotics fellowship, most of it's primarily oncology work. So we're really excited to have Dr. Nasmi in town. We're just waiting a few more weeks for hopefully a few more weeks for the license to kick in. I'm going to talk to you about things for advanced prostate cancer tonight. The first half of the talk concerns Provenge, which you may have heard me talk about Provenge before. They're helping sponsor the food and everything tonight, so we appreciate their support. The Provenge, and then the second will be on a newer drug that's available as well for advanced metastatic prostate cancer that's no longer responding to hormone therapy, especially when it's in the bones. And that's a drug that is going by the name of Xofigo. And what it is radium-223. So we'll spend some time talking about that too. But Provenge, so first of all, who's the candidate for Provenge? Well, Provenge is indicated for men who have prostate cancer, and it has to be metastatic, meaning there's bone scan or a CAT scan showing evidence that the cancer has moved elsewhere in the body. It doesn't matter if you have surgery or radiation. It just means that. And also, this spread has to be despite hormone treatment. Okay, and so you're on hormones, or you've been castrated, and the prostate cancer is moving along. It's in the bones, and usually your PSA would be going up as well. If you're not having too much pain, meaning you don't have to be on narcotics, that's the indication basically for Provenge. Now, if you're taking narcotics for something different, like you have chronic back pain, that's a different story. But if the official indication was for patients who are not suffering severe pain, and that's because this, as I'll explain, this drug takes a while before it starts to work, and so there's worry that if you're already having severe pain, you may not have enough time for that drug to work, and you're probably best off with a different therapy. So we'll also talk about other treatment options in prostate cancer that are in the advanced state. Talk more about Provenge, and what would be germane to us is, well, what's the experience if you're undergoing such a treatment, and then finally, how do you pay for it, which is always important. First of all, prostate cancer, as you all know, is a very common disease, but as you also know, we're learning more and more that not everyone who has prostate cancer necessarily needs treatment. And that's a whole other talk in itself, talking about that and the whole PSA controversy. But overall, 1 in 6 men will get a form of prostate cancer. Now, if you go on to treatment, you have surgery or you have radiation, not everyone's going to be successful with those treatments. The cancer can potentially come back. The number they quote is 1 out of 3. I would argue that number is lower today. I think the number is probably 1 out of 4 or 1 out of 5. Probably 1 out of 5, but still that's a significant number of people who may come back with disease, even though there's been an attempt at cure. And eventually, if you live long enough and the cancer continues to move, eventually it will spread or metastasize to other parts of the body. And that happens in almost everyone, over 80%. So Provenge is this orange box. It's an immunotherapy, and what immunotherapy does is it actually activates your body's immune system to go out and attack whatever it's been triggered to attack, in this case, the prostate cancer. It's different from hormonal therapy and chemotherapy. This audience probably already know hormonal therapy is the original treatment for prostate cancer. It's how someone won a Nobel Prize for making the observation that castration can freeze prostate cancer. And eunuchs never really develop prostate cancer. The hormonal treatment is now commonly given with drugs like Lupron or Eligard, so you could have castration if you're inclined as well. Now, chemotherapy also is a treatment for advanced prostate cancer, and that's most of you, if you need to go that route, are going to have, nowadays it's pretty much Taxotere as the first line chemotherapy. It's been shown to extend survival. It's fairly well tolerated. You usually don't have to be in the hospital. Usually you don't have too much problems with your bone marrow going out while you're on treatment. So Provenge, how does it work? Well, first of all, Provenge is the first immunotherapy, actually for any, it was the first one for any cancer line. It's the first immunotherapy for prostate cancer that has been approved. And as you'll see, it's actually a very safe treatment. And the way it works, you can see that cell moving, that's your immune system. What happens is that your immune cells usually will recognize and destroy viruses, bacteria. Now, prostate cancer cells can outfox the immune system. Even though it's not a typical cell, your body doesn't recognize it, and that's how these cells can grow. So what if you could reprogram your immune system where it actually would recognize these prostate cancer cells and therefore attack them? Well, that's what Provenge aims to do. It aims to train or educate your immune system to get these resting T cells and boost them, so to speak, where they start to multiply and know that they're supposed to seek out your prostate cancer cells. So, it's basically like you're a coach. So one thing right off the bat is apparent is that you have to have a working immune system in order to use Provenge, and that we can talk about later is important, and how sometimes we sequence these advanced these treatments for people who have advanced prostate cancer. This was the clinical study that basically led to approval for Provenge. And you can see orange is the patients who were given Provenge, and year after year the Provenge effect maintains itself. The treatment is given in a span of 5 weeks. You can be done with the whole thing. But the effect can last over years. And at 3 years, we're talking about people who have advanced disease, okay? So not everyone's going to survive if you have advanced disease. But in 3 years, you can see that there's a 38% increase in survival if you had Provenge versus if you didn't have Provenge. One other thing that's really important with this drug is that, unlike everything else, surgery, radiation, chemotherapy, hormones, Provenge doesn't directly affect PSA. In fact, it's kind of strange. We disregard PSA initially when the treatment is given. And that's because, again, we're trying to stimulate the immune system, so there's not going to be an immediate kill, so to speak. And when there's an immediate kill, you start seeing drops in PSA. And so even if your PSA doesn't necessarily decline, and in the studies they couldn't really show that it declined, it still doesn't mean it's not working. So in the clinical trial, they showed these guys, what's the most important thing? Well, you live longer, and in the clinical studies, the patients lived longer when they were given immune therapy. In real life, it's a little bit harder. We don't want to just give you Provenge and okay, that's it. No, we're actually trying to see, because Provenge can, it can fail. It's just one of the treatments out there. What we'll do in practice is I'll try to ignore your PSA for the first few months, 3-6 months, and then we'll get a bone scan and PSAs at that point. And usually if patients are feeling fine and the bone scan is not progressing along, we'll just keep things as is. If perchance the bone scan's worsening, well, this is real life. We're going to, see what else potentially is out there. We're not just going to let things ride. So this drug is really easily tolerated. It's given in the office. Like I said, it's the patients can get this all done within 5 weeks, and their flu-like symptoms are the main side effects. Fever, some chills. This is really all I've heard. Even the chills really haven't been a complaint, because sometimes we'll get Demerol if patients complain of chills, and we've never had to do that. But some muscle aches, some joint pains, and it goes away. We haven't had to hospitalize anyone, and in the study it's very uncommon for anyone to have been hospitalized or to have stopped Provenge. Over 98% of the patients who started it were able to finish it. So there are some serious side effects in the studies, such as breathing problems, chest pains, irregular heartbeats, dizziness, nausea, or vomiting. Again, those are all things that we look out for, but 98% of patients were able to finish Provenge. So it's immune therapy. It's personalized. It uses your own blood. What happens is the first time you come in, you go and get your blood drawn. And there's a few centers around town that are called apheresis centers. They draw your blood. They take it and ship it to the Provenge plant. There's a few of these across the U.S. And in the plant, the cells are exposed to basically prostate cancer cell lines that have been charged with immune stimulators. So it makes your immune system recognize these cells, and then you start to build up antibodies and T cells that are now going to be reinfused into your system, ready to attack these prostate cancer cell lines. When you come into the office, what we do is we pre-medicate for about 30 minutes, Benadryl, Tylenol. We start hydrating, and then you get the treatment. The treatment lasts about an hour. Usually you bring your wife or your iPad, whoever you like to talk to more, and then that's really about it. And then 30 minutes of observation after that. Again, you can see you get 3 cycles. That's currently how we deliver Provenge. There's studies ongoing looking to see if maybe we should be doing boosters, just like if you're a child, you get your immune vaccines, and then you get a booster later on. But right now, the way it's approved is 6 appointments, 3 in our office and 3 in the apheresis center. And they're spaced out where really you can be done in 1, 2, 3, 5 weeks. Financial assistance, well, if you need Provenge, most people are able to get it. That's bottom line. It's a very expensive drug. I think as a first-in-class type of drug, that's to be expected. Hopefully, they'll get it where the prices come down. I don't think they have a choice but to make their prices go down because it's a very expensive therapy. But fortunately, Medicare is covering it, and they have a lot of assistance programs for patients who may need help with out-of-pocket costs. You can see that 75% had 0 to, on average, $50 of out-of-pocket costs. And the company, I have to say, has lots of programs where they help take care of this. You have enough to worry about, and they're very helpful with trying to address the financial aspect. So basically, this drug has been recommended. It's got a Category 1 recommendation from what we call the NCCN guidelines, which are National Cancer Guidelines. It's for men who may or may not have had chemotherapy. You could have had chemo, but usually it's going to be for the person who has metastasis, where hormones are no longer working, PSA is starting to go up, and you have no pain or pain that does not require narcotics. And this leads into, I think what we can do is, if you want, I'll just jump into the next part. Let me go over the summary slide. Again, treatment program activates your immune system. It prolongs survival. It can be completed in 6 visits, 3 to the apheresis center and 3 to the urologist's office, all in a span of about 5 weeks. The side effects are very mild, and there's help if you need it for financial assistance. And basically, this just goes into more safety information that we talked about. It can cause serious reactions. Again, 98% were able to finish treatment with Provenge. Most people will complain of some fever or chills. I mean, if you have side effects, that's usually a complaint. Flu-like symptoms. And you need to call the doctor if you have a fever over 100, or you start getting redness at your infusion site or where they collected your blood site, just because those might be signs of infection. And obviously, we'll do it in intake, looking over your overall health condition, what kind of medications you take, to make sure you're. Oh, see, I did this last stop when the Spurs were in Game 6. So, unfortunately.
The flow chart about 6 slides back made it look like it could be used a little sooner than I understood from the first listing.
Yeah, so it can be used after hormonal therapy. Hormones have to be on board first.
Okay.
That's the rule. And then Provenge is up.
Once the hormones are no longer.
That's the FDA. When the drug was tested, it was tested in that population. So, but that's a game we have. That's a game that companies have to play. They first approve it in these populations, and now they're doing studies to see if you can get them earlier. So it's very hard to because of the price. It's hard to deliver Provenge off label because you don't want the insurance company to say, "Well, yeah, you can take it, but who's going to pay for it?"
So what is the price?
Price is like $93,000. So your immune system's a pricey thing.
Yeah. So after hormone therapy is failed, or right? Is that when it?
After hormonal therapy is failing.
Yeah, no longer effective. Okay.
So, Dr. Keller, so a person like myself, I had surgery, okay? Now I'm 13 years out, but should mine come back, I would go to radiation first, right?
Well, probably, but it'll be a conversation. What was your pathology report? Did you have, for example, positive margins? How long ago was the surgery? Because you may not need radiation. May not, you don't want to get it if it's not going to work. So we're going to look at other factors. But yes, typically, if surgery doesn't work, then radiation is usually the next step.
And then hormones.
And then hormones.
And then Provenge.
And then Provenge. Provenge, some doctors will suggest other drugs too, like Zytiga, which has been approved recently. There's another drug coming soon in this space called Xtandi. Right now, Xtandi is only approved if you fail chemotherapy, Taxotere. So the space is getting more crowded. Now, my preference, I'm not talking costs or anything, but if it were me, I would want the immune therapy. Obviously, it's very benign to your body, and it's in a way, in my mind, I kind of think of it as being natural. I'm just stimulating my immune system. So I would try to do that before I try some of these other drugs.
Are there going to be any other factors involved in whether you're ready for this treatment, able to get this treatment, like medical conditions, age?
No, age isn't a consideration. Really, maybe longevity. We might have that discussion. If you're.
Is that a form of chemo?
No, it's not chemo. It's a totally different class called immune therapy. It's a class of drug called immunotherapy, using your immune system. So no one would call it chemo. but yeah, like determining if you're going to get it, again, it's going to depend on, you know, you want someone who's kind of healthy, because it takes a little while for the ProVention to start working.
You know if it's going to run up against any of the new affordable care?
You know, it may, I doubt it, but it may. You know, if they try to cap your cost, for example, you know, you have $200,000 set aside for fighting your prostate cancer, then it may. But I also think this price will start to drop. Is my feeling.
For my father, he had surgery. He started hormone therapy recently, and then they're now gonna. He's gonna start radiation soon. But the diagnosis was basically that it extended past his prostate. He had his whole prostate removed. So, would Provenge be an option for him at this point, or does the hormone therapy for sure has to?
Whether or not you need to be on hormones before you do radiation that's something that some people will put you on it, some people won't. You know, when you start hormones, there's a lot of side effects that you may suffer through. So that's something, you know, I could maybe talk to you after to kind of look over the report and stuff to give you my opinion on what I would do. In the back, yes.
Kelly, is there any way to evaluate the strength of the immune system?
Yeah, I think. What do you think? Evaluating the strength of your immune system.
In general, if patients aren't getting infections that people with normal immune systems don't get, then the immune system is assumed to be okay. When we start as doctors to get an idea of the immune system being not okay, 95% of the time I would say it shows up with some sort of infection or problem that you have that people with a depressed immune system tend to get. As physicians, we know what these things are. Sometimes non-healing wounds can be something, or bleeding longer than you should be can be signals to this, but in general, there should be no reason why people's immune systems are depressed, so unless there's an issue, that means yours is fine.
You know, with Provenge, since you can't measure really PSA, some people have talked about measuring, there's this thing called circulating tumor cells, CTCs, and I would think if your immune system is working really well with the Provenge, you'd see a steady decline in your circulating tumor cells. But otherwise, there's really, you know, it's basically how is your body doing? How is your body doing relative, like just like Dr. Macy said, overall with its ability to fight off all sorts of other infections. Let me. Want to go ahead and do the second presentation. Okay, so this is a Radium-223. Okay, sounds like a class. Radium-223 is a new drug, and it's now given a name called Xofigo. It's made by, or Bayer acquired the rights to this drug, recently approved, and now available. It's a nuclear medicine. So you can't just get it at the pharmacy or in any doctor's office. You have to be certified in order to deliver this treatment. Yeah, oh man, someone already got it. Who said that? Yeah, the scream. You know who did it? Oh, I put it on the bottom. It's small letters. Yeah, Munch. Yes, the scream, 1893, but signifying like a problem when you have, what problem is Radium-223 trying to address? And it's trying to address situations where you have pain or possibly spinal cord compression from metastasis, fractures of your hip due to the cancers. It's trying to address really serious problems with bone metastasis of prostate cancer. Right now, there's lots of shortcomings in treatment of skeletal metastasis if someone comes in and they're on hormone therapy and now they have a bony metastasis and it's causing extreme pain, if there's just one, what we'll do oftentimes is send you for radiation. Well, the radiation can only treat that one area, and it can hopefully sterilize it, but it's really kind of treating everything in that area. So all the bone marrow in that area is going to be gone. Now, if you have metastasis all over your body, they're all starting to cause pain. That's even a bigger problem because you can't, shooting the radiation all over your spine is going to be a very tedious process. It's just not done that often. In that case, you would go on to things like chemotherapy if you haven't had chemotherapy yet. And chemotherapy, as you know, is a IV infusion and it has a lot of systemic side effects. Really, chemo is just something that kills anything that grows quickly. So it's assumed that that's why your hair will drop, because your hair grows quickly, your nails turn brittle, and why your cancer is usually killed, because those are all fast-growing cells. With prostate cancer, it usually goes to the bones. It prefers bony tissue much more than it does soft tissue. And that's really how patients will start to die, because once it goes into the bones, it starts to squeeze out your bone marrow, replaces it. Your bone marrow is what makes all your blood cells, and you basically waste away, you develop lots of pain because of just this mass being in your bones, and eventually succumb to the disease. So radium-223 is what we call a bone-seeking radiopharmaceutical, a BSR. And it's not the first BSR that's out there, but I think it's going to be one of the, it's going to take over what is out there, and it's going to reinvigorate this field, so to speak. And it's going to be an exciting area of new treatment where we didn't really have anything good before. So the other BSRs, we have one called Quadramet or Strontium 89, and it's a very toxic drug to your bone marrow. A lot of people will need drugs that can help promote bone growth once they've been on this drug. And it's what we call a beta particle emitter, and I'll talk about what beta particle emitters are. The other one is samarium, and samarium-153 is really not used that much either. It's usually combined with chemotherapy with Taxotere, and it also can have some suppression on your bone marrow, which is not good. And usually, because of the side effects of these drugs, and also because metastasis start to happen later in the course of the disease, usually people got these BSRs towards the end of the disease process. And up to this point, none of these drugs improved survival, so they were just given really for pain, to try to help palliate patients. Well, radium-223 is different. It actually is, what it does is it seeks out bone, so it's a natural bone-seeking molecule, and it has a high, what they call cytotoxicity, meaning it will kill DNA, not just in one place, but on both strands, so it makes it real hard for the DNA to replace itself, so those cells are going to die. And importantly, it's what we call an alpha particle emitter, which is different than the beta particle. An alpha particle emitter has a very short distance of action versus a beta. So by being alpha, you only destroy cells that are in a 6 to 8 cell circumference. So it's like smart bombs, very pinpoint activity. And it can work if chemotherapy has failed. It can work if radiation has failed. What does the body do with this? Do we have to worry about side effects? Well, fortunately, the drug is metabolized where it goes directly into your gut. It doesn't interfere with the liver. It doesn't interfere with the kidneys, and it's excreted. By day 6, it's pretty much in your gut. So it's either on its way out or it's out already. Another thing that's important is that when it's metabolized in the gut, you're worried, is this going to affect am I going to start bleeding, having bloody stools? That mucositis, it doesn't happen. It's injected. You can see the injection going on here in the office. It's taken up rapidly into the blood system, and it starts going towards metastatic bone activity, meaning where there's a lot of activity in your bone, and that's where the drug shoots to. Here you can see a CT scan. Those white areas are bone metastasis. And then there's a mock-up here where you can see, it's a little bit hard to see, but those yellow areas are metastasis. That's a prostate cancer, and that's in the middle of the bone marrow. And these little areas is where the drug is going to focus. So here you can see on that top left picture, there's healthy bone marrow, and then there's that area of tumor cells. That yellow area down below is the drug. And the drug focuses on those areas where the bone, where there's increased bone growth going on, and that happens to be where the prostate cancer cells are. And then they're close enough where they start to kill those cancer cells. This shows up better. Sorry, those other images just kind of get washed out a little bit, but this is a good representation of the blue line is what's out there right now. Those what's called a beta emitter. You see how it has a wide blast area, but then the red is the alpha emitter, and it has a much more focused area of activity. So you're not going to kill off a lot of that healthy red bone marrow. The administration, again, it's very easy to use. It comes, it can sit on the shelf. It's easy to handle. You do have to have a license since it is radioactive. It's one visit per IV dose, and it's 4 dosings, one every 6 weeks. It's done as an outpatient, and the most important thing is radiation, but there's no restriction on going home and hugging your kids or your grandkids or your spouse. The study that led to the approval of alpha, it's known as alpha-radin, radium-223, and now Xofigo. But they looked at 900 patients. Again, it was 6 injections every 4 weeks, and they found not only did it get rid of these bone metastases, these painful bone lesions, but it actually improved survival. So it was much better than all the previous bone BSRs, the bone radionucleotides. It increased median survival by 3 months. It increased the time it took to reach what's called a skeletal event, which means a bone fracture, for example, or the need to get surgery for a bone lesion. Interestingly, it does not affect PSA that much either. And they think that's because it's only affecting the areas that are in the bone. So if there's other prostate cancer floating around in your system, it's not going to get attacked. And it doesn't matter if you had chemotherapy before. It'll work regardless of chemotherapy. These slides I can kind of save. We can talk about it if someone's interested, but there's existing drugs called Zometa, Xgeva. Those don't help. Those do not fight prostate cancer metastasis. They hopefully just keep the bone strong enough so there's not going to be a fracture because of the bone metastasis. And they compared in the study. They had a placebo arm and then the treatment arm, and amazingly, the treatment arm had less side effects. So actually, the people who got placebo had more side effects than the patients who received treatment. The way the study was set up is that if you're a placebo, you got the existing standard of care. Whatever's cutting edge, whatever the doctor deemed in your best interest, that's what you got. In the other arm, you got the same thing plus the drug. And they're looking at, again, sequencing is the big buzzword now in advanced prostate cancer, meaning we've got all these drugs, what's the best order to give these drugs to our patients? And that's really what we're trying to find out. And that's the last slide I have on Alpharadin or Radiant 223 or Xofigo. So yeah, I'll take questions again on this or anything.
Did I just understand you could do ProVenge and the 223 at the same time?
No, you probably won't have that happen because 223 is for painful. I mean, it's usually given later on. You can, and I bet you that will happen. But right now, scientifically, there's no reason you can't do it. To me, it makes a lot of sense. But we'll just have to see if it's an insurance thing. And we're actually just gathering data on it ourselves too. But theoretically, it makes sense. But I don't know what the data says yet.
Well, ProVenge has been out, 3 years now?
2010.
So y'all just have data for 3 years.
Mm-hmm. ProVenge. But Xofigo's been out for this year.
Is there any indication how long, once you train an immune cell to recognize prostate cancer, how long will it retain that memory? Or will
It goes on for year after year. Like in the 3 years that they follow the patients, there was a persistent, the guys who had ProVenge persistently did better. So it wasn't like after 2 years, all of a sudden the curves came back together.
Are they looking at any benefit of administering ProVenge before prostate cancer is diagnosed?
They're looking at giving ProVenge again, like a booster. They're looking at giving, before diagnosis?
Yeah.
Probably when it's $10. And we'll do that. Not right now. They're looking at studies where, as soon as you have a diagnosis, there's one study I know where they give you a ProVenge then to see what the long-term effect
Doctor,
is going to be.
I got something from Wall Street Journal here. It's past Saturday, and I don't know anything about it. And I figure if they can get rid of it by freezing, what else does it freeze besides the cancer?
So this is we can freeze and destroy cancer cells in your prostate. This is a cryotherapy. Cryotherapy has actually been around since the 1970s, and it's just become more sophisticated, just like radiation's become more sophisticated, surgery's become more sophisticated. They're offering cryotherapy for patients who come in with a new diagnosis of prostate cancer, or potentially you've had radiation, and now they know prostate cancer is growing again in your prostate. They can spot treat that area potentially with this cryotherapy treatment.
Well, it had been mentioned to me, and I just was asking the question because I don't know.
Yeah, no, cryotherapy is actually one of the. Usually cryotherapy is like for someone who is surgery or radiation are actually proven to be better treatments. Then those are the only two treatments that have been shown to extend survival. Cryotherapy hasn't been shown, but it definitely has a role. Okay, despite that. So it's, for example, a guy who's gotten radiation, and now he's older, maybe not as in good shape to withstand a surgery, because it's very difficult to do surgery after radiation. But we know that the cancer is just in the prostate right now, and we don't want to let it just sit there because eventually it's going to spread. Well, that's a patient who may be a great candidate for cryo, where it's basically it's like popsicles. You take a little probe, it literally looks like a straw, or a little tiny sharp straw, and you stick it into the prostate underneath the scrotum. You lift up the scrotum, you poke these needles through the skin right into the prostate while you're looking at it with an ultrasound, and you turn on the freezing machine, and you actually watch these little ice balls start to form on ultrasound. And then once the ice ball's been formed, you turn off the machine, and you're like kind of looking at the ultrasound. Now ultrasound is what determines how the treatment goes, and that's the biggest problem, is that ultrasound, when it reaches a solid interface, a change in interface, that's when you get your echo. So with an ice ball, you can't see beyond that ice ball. It looks black. So the problem that's always existed in cryo is, what are we treating if we can't see behind that treatment line? It's kind of hard to explain, but basically that's why cryo usually has a lot of problems with nerve damage. Most people get cryo for the whole prostate, kind of impotence. And that's why we kind of save it for patients who really surgery or radiation is not an option. Cryo takes a lot of experience, so if there's a guy at Cleveland Clinic who's doing a lot of them, then I would go see him because there's not a, most people in town now are, we used to do a lot of cryo in town, we don't do that much anymore because the other treatments have gotten so much better. Yes.
Times can the 223 radiation be administered as a therapy?
Great question. Right now, it's given 6 times, and every 4 weeks it's tolerated very easily. I anticipate they're looking. I don't know if they are for sure, but I anticipate they're going to be looking at readministering it if the cancer continues to come back in the bones. The problem is at some point it may go into your soft tissue, and if it goes into soft tissue, then the radium won't work because it just hits calcium.
So you're talking once a year, six treatments is the entire course of it. And you can do that once a year? You have to wait another year before you do it again?
No, I'm talking just on my own because I don't have data to back it up. But yeah, I would say if I had a patient and they came back again with bony lesions and they responded to the Xofigo, I would try to give it again.
Because I know the Quadramet you can't give that.
Quadramet wipes you out so bad that you can't do it again.
Gotta go outside for just a minute. Did you cover anything about omega-3 and the so-called new information that's in the news?
No, we didn't. My quick little thing on omega-3s, there are a lot of other studies that have shown benefit with it, so I would hesitate on throwing out omega-3s with just that one study. Counseling patients just to, if you're taking it strictly for prostate cancer, well then maybe just get it through your diet and you can wait and see. But that was really amazing because there's plenty of other reports showing that it has helped.
Yeah, that was kind of limited to a certain supplement almost or something like that. It seemed.
Yeah, I think there's going to be more that comes out on that. I don't think that story's over yet.
Dr. Keller, side note, cryotherapy. About 4 years ago, we had a urologist talk to us, and then I went to see him about the possibility of cryotherapy about maybe a year after that. And he told me, he said, well, I'm not doing cryotherapy anymore. He said he had done over 400 with treatment. And he said the reason I quit is because of the horrible infections I became. And he said he had places that actually crystallized to the abdominal wall.
Mm-hmm.
It was so bad, and he just gave it up. So have they figured out a way to reduce those infections?
I think cryo is very dependent on the surgeon's experience and selecting the right patient. So, if someone came to me for cryo, I would say, look, you don't want me to do your cryo because it's been a long time and I don't want to make a popsicle out of your rectum. So, a lot of experience that's needed. Because you're monitoring a lot of moving things on that ultrasound. And, if one of those little ice balls gets out of control and you didn't notice it, then there's not much latitude around your prostate for mistakes.
The one slide, you touched on it a little bit, the relationship between the bone mets and PSA, and if the 223 doesn't really drop PSA. Does that mean that a metastatic prostate cancer isn't giving off PSA and that they are somewhat independent?
I think metastatic prostate cancer usually will still give off PSA. The reason I think in the study and what I heard some experts also talk about is that there's other prostate cancer cells in your body that haven't attached to the bone, and those are still making PSA as well.
Right. Yeah, there's obviously a bunch still floating around in the blood and soft
Right.
tissue. So.
But that being said, the drug extended your survival.
Yeah, well, I was kind of asking if you could kind of use PSA as an indicator or.
I'll use your how your pain responds and also another bone scan. All right, great.
So now they've got, in this month's hot sheet, now we have watchful waiting and now we have active surveillance. Now, why is the docks clouding up the water again? Now we had no PSA, you don't want mammograms, and now.
The pendulum is swinging very hard right now, and what should have been a slow bring back, there's patients who maybe don't need aggressive screening or aggressive treatment. The task force that was charged with making recommendations didn't have a single oncologist or urologist on the task force. Then the second thing is that the studies that they looked at were really, for what they were trying to achieve, were remarkable. They were trying to see if you screen patients or you don't screen patients, is there a difference? And they had a big U.S. study and they had a big European study. Well, you can't, humans aren't like animals. A human's going to go and get his PSA checked because he runs into a doctor and says, well, we're going to check your PSA. He's not thinking, oh, I'm in a study, I'm not allowed to do that, doctor. So a lot of the patients who are supposed to have never have gotten screened ended up getting screened. So it muddied the studies. And that was another big problem with the studies that they looked at. And then the other thing is that the studies had a really short time period. Prostate cancer, it's not like melanoma where you're on the operating room table yesterday. It's a slower growing disease, but it is a disease that can kill. And in the studies, they have 7 years, 8 years follow-up. And for a lot of guys, that's not long enough to see a benefit. Because first question I ask someone is, I don't really ask it to you like this, but what you're thinking in your head and what you're trying to get the patient to understand is, what are my chances over the next 10 or 12 years that I'll be alive? If there's a good chance I'm going to be alive, then we'll talk about doing treatment for prostate cancer. Well, these studies only looked out like 7 years. So they've modeled some of these, and they've shown that, hey, wait a second, if you actually modeled these studies out for a longer period of time, that the number of patients you need to treat who have prostate cancer in order to save one life, ideally would be 1-to-1. Every person you operate on is a person whose life has been saved. But screening efforts look for ratios that are like 7, 8 to 1. So for breast cancer or colon cancer, not everyone who gets treatment, unfortunately, is going to. Not everyone who gets treatment is going to be saved because of that treatment. That's just inherent in screening programs. But they've showed that when you model these studies out, basically prostate cancer is just as good as colon and other big screening initiatives that we do, like in breast. So I think the pendulum is going to come back a little bit, but I think urologists know that we have to be smarter with how we screen, and we have to offer treatments that are going to minimize side effects. And a lot of that has to do with, just like cryo. If someone says, hey, you're going to do my cryo, and we say, no, I'm not. Surgeons have to know where their shortcomings are.
But the active surveillance now, so if you're on AS, then you do the biopsies, you do the DRE, you do the PSAs. But if you're on WW,
Don't do anything. WW is probably just watching your PSA. Active surveillance implies that you're going to be doing something active, meaning getting another biopsy at some point down the line to confirm that nothing's worsening. I think is that how you describe the difference?
Absolutely. Active surveillance involves a protocol where repeat biopsies are done every so often until either you choose treatment or choose to go off active surveillance. With watchful waiting, now watchful waiting involves kind of checking the PSA. 10, 15 years ago, watchful waiting would be nothing, not even checking it.
It wasn't watchful, just waiting.
Yeah.
I submit to you that pine box is a real serious side effect. And this, when I hear people talk about, when I read these things about the awful side effects, they totally ignore the pine box is out there waiting.
Oh, the pine
Or-
box. Got it.
Yeah, is waiting. Okay.
New cremation.
The But the Pine Box is waiting for a percentage of these people that they ignore. They write those people off. And it really perturbs me.
Yeah, I mean, there's lots to be said for, I mean, we do need to be more educated in how we offer treatment and screening to patients, there's no doubt. But at the same time, I think the recommendations, if you look at the data they use, what I was talking about earlier, it's kind of, I'm sure it's just a matter of time before it's going to get fixed up a bit. All right. Well, I'll be happy to talk to anyone. I don't know if you have other things in the program, but I'll be standing over here. I suppose if anyone has any additional questions.